Good afternoon. I'm Linda Shortliff, Professor of Urology, and I'm happy to moderate this session for you this afternoon. It's now my great pleasure to introduce Dr. David Spiegel. Dr. David Spiegel is Professor and Associate Chair of the Department of Psychiatry and Behavioral Sciences. He's also the Director of the Stress and Health Center for Stanford. He's examined the effects of stress, emotions, and support on health, and hopefully today he will also be talking about some of this in addition to his work on mind-body interactions and hypnosis. I'd like to introduce David Spiegel, Losing Sleep with Cancer.
Thanks, Dr. Shortliff. Well, we're here to talk about sleep and cancer. There was a famous columnist in New York named Max Lerner, whose son is Michael Lerner. Actually, some of you may know him. He does alternative cancer treatments here. And Lerner said, "I had a dream that I was lecturing to my students and woke up to find out that I was." Sleep and dreams are a very important part. They're a third of our life. We spend our time sleeping more than doing just about any one single thing in life. And yet we tend to pay far too little attention to it. And I think one of the odd things about people getting cancer is that suddenly they get it in their head that the thing that is now the only threat to their life is cancer. So they make two mistakes. Number one, they pay very little attention to the other things that are actually more likely. Now more than half of all people diagnosed with cancer will live to die of something else. So it's still more likely, even if you're diagnosed with breast cancer, you're more likely to die of heart disease than breast cancer. So watching your cholesterol, fat in the diet, smoking, exercise is more likely to save your life than doing a lot of other things that have to do with the breast cancer. But the second thing is we tend to not recognize that our bodies need to be in training for the toughest fight of your life. And that means that just the way you would train for a marathon or a performance, you need to train to help your body live with cancer. And that means getting plenty of sleep. We're all in this culture sleep deprived. Artificial lighting allows us to stay up much later than we should and entertain ourselves with all kinds of silly activities until the wee hours of the morning. And so we tend to be sleep deprived, and in many ways that's bad for your body and makes it harder for your body to deal with cancer. So what I'd like to do is talk to you a bit about stressors related to cancer and sleep in particular and what we can do about it. Cancer is a stressor you can't forget. This is a dressmaker's maquette that was done by one of my patients who, before she died, gave me her permission to use her name, Maurice Jaffe. She was a Silicon Valley engineer, and when she was diagnosed with metastatic disease, she quit her job as an engineer and decided she was going to do what she wanted to do all her life, which was be an artist. So she went to art school. She was teaching art and produced quite a body of art before she died. And this she dragged into the middle of one of our support groups one day, and obviously there was nothing else to talk about that day. And it was a reminder of everything that had happened to her body as a result of cancer and its treatment. So she'd had a modified radical mastectomy, a tram flap reconstruction, she had radiation burns, she'd had an open biopsy on the other breast, and it's a reminder that cancer is not one big stressor, it's a series of stressors that follow you around all the time. And we need to learn to help people live better with that, including sleep better with it. So I'll talk a little about stress, distress, and cancer. Stress-related factors like depression that can affect cancer, circadian patterns, that is day-night patterns of hormones like cortisol that can also affect disease progression. Specifically then sleep disruption and its effect on disease progression, things we're trying to do now to help cancer patients sleep better with the disease and what effects that this kind of stress management may have on disease progression. So I would present evidence that helping people manage the stress of the disease better, sleep better, is not only good for quality of life, but it may actually be good for quantity of life. Clearly, something has changed. We used to think of cancer as a terminal illness, and now, thanks to many advances in medical treatment, we think of it more as a chronic illness. In 1971, there were just under 3 million cancer survivors in the United States. Now there are 12 million. So there are a lot more people living with cancer, and that means that helping them find better ways to live with it is a very important thing. There have been several reports from the Institute of Medicine and the National Academy of Sciences that talk about how to help people in this transition from being acutely treated with cancer to living with it. They call the report From Cancer Patient to Cancer Survivor Lost in Transition, which is a clever name. And they talk about the need to develop systems of treatment and support to help cancer patients. And in another report, Cancer Care for the Whole Patient, they say addressing psychosocial needs should be an integral part of quality cancer care. Evidence supports the effectiveness of services aimed at relieving the emotional distress that accompanies many chronic illnesses, including cancer, even debilitating depression and anxiety. So as I mentioned, cancer is a series of stressors. They're things that will keep you awake at night. The existential questions. As I mentioned, half of all people diagnosed with cancer will live to die of something else, but everybody told they have cancer thinks it's going to kill them. It's the first thought they have. So being able to face and live with the existential issues is important for every cancer patient. There's pain, which can interfere with sleep. There's worry about the diagnosis, fear about treatment, important decisions to be made, and changes in your social environment. Your life is different. You don't see the same people every day. And that can have profound effects on daytime but also nighttime feelings, and reduced physical abilities, changed family roles. One of my French cancer patients, who was also an artist, depicted cancer as the word literally means crab. It was described by the ancient Greeks as a crab-like growth, and so she depicted the crab having taken the place of her hair. And one interesting thing about cancer is people feel attacked by the disease. You know, if your kidneys or your heart let you down, they're just not doing their job well. But cancer is a part of your body that has become the enemy. And so many people feel uncomfortable in their own bodies, knowing that there are cells in their bodies that are trying to do them in. So she wrote, "The villain crab goes on the attack." And often the treatments are very hard to undergo too. Unlike other medical treatments, which immediately make you feel better, cancer treatments immediately make you feel worse. They're necessary, but Susan Love called it slash, poison, and burn, that the treatments feel worse than the disease for much of the course of cancer. And there's a great sadness, she said, that goes with it. And in fact, the rate of depression, which is often associated with sleep disruption, and the kind with depression is often early morning awakening. So you get to sleep all right, but you wake up at 4 or 5 in the morning, you can't go back to sleep. That often goes with depression. And about a quarter of cancer patients suffer from clinically significant depression. People who are depressed aren't just sad. They feel hopeless, helpless, and worthless. Some of them think about ending their lives. And they're hard to be with. So often people around them get angry with them. They want to shake them and say, come on, it's not that bad. And that doesn't work. It doesn't help people out of depression. There's evidence that depression with accompanying sleep disturbance is associated with more rapid progression of cancer. So 15 of 24 studies showed that patients who are depressed do worse with cancer. And this is a study that we just published in the Journal of Clinical Oncology a few months ago, in which we tracked the course of depression over a baseline year among women with metastatic, that is advanced breast cancer. And what we found was that those whose depression kept getting worse were going to die significantly sooner, up to 15 years later. So it's not as though they were just getting depressed 2 months before they died. This was a predictor years out, and independent of all the other known risk factors for mortality from breast cancer. So comorbid depression and sleep disruption are a risk factor for more rapidly progressive cancer, and the average difference from those whose depression was getting worse in the baseline year to those who was getting better was about 2.5 years. So it's a significant difference in mortality just based on depression. Now, there are many ways to treat depression. This is a freeway in New Jersey. But I won't talk more about the treatment except to say that it's a very treatable illness. And we think that stress and depression may have an effect not just on quality of life, but on stress response systems in the body, hormone systems, that can have an effect on immune function and on tumors directly themselves. If you think about it, there are two parts of the equation. There's the cancer itself, and there's the body and how it reacts to the cancer. And it can create an immune environment that is more hostile, that can prevent tumors from growing. Tumors often have ways of disabling components of our immune system. There are also hormones that can affect tumor growth. We know that one of the most effective treatments for breast cancer are hormone blockers, like tamoxifen, which blocks estrogen receptors in tumors, or Arimidex, an aromatase inhibitor that blocks the production of estrogen in the woman's body. Both of them are very effective in reducing the growth of cancer, but stress factors can also affect how the body reacts to cancer. So there's a system that it connects the brain to the adrenal gland, which sits on top of your kidneys and secretes two stress hormones, epinephrine and cortisol. Epinephrine increases your heart rate and blood pressure. Cortisol mobilizes glucose into the blood. It's an anti-insulin in a sense. Insulin stores glucose, takes it out of the blood. Cortisol mobilizes it into the blood so that you're ready to fight or flee. And it's elevated when we're stressed. It's also higher in the morning than later in the day. And there's a very delicate feedback system that says, okay, you've had enough cortisol, we're going to shut it off. And most of the time that allows us to respond to stress when it's there and turn it off when it's not. But as I mentioned, cancer is a series of stressors that bother you during the day and keep you awake at night. And the effect has been called allostatic load by a researcher at Rockefeller named Bruce McEwen. And the idea is that it's not the one big hit to your stress system, it's the collection of little hits that can have the most damaging effect on your bodies. So you expect the stress system to turn itself on and then turn itself off here, but sometimes it's sort of like breaking a light switch. If you turn it on too often, it just stays on, or it may just stay off, and then you're not responding appropriately to stress. So in the day-night cycle, cortisol levels are highest when you first wake up in the morning. As you know from this morning, waking up is a daily stress task, and your stress hormones are about as high as they're going to be when you wake up. By now, right after lunch, they should be down about here, and by the time you go to sleep, they should be about a quarter as high as they are in the morning. But people who are depressed tend to have relatively high and flat profiles of cortisol, so their cortisol levels tend to stay very high. People with post-traumatic stress disorder have flat and low cortisol levels. And we found that the majority of women in our sample with metastatic breast cancer had abnormal patterns of the stress hormone cortisol. And that in fact, the ones who had the most abnormal patterns, where the stress hormone was high throughout the day, also died sooner. So it was like the effect we saw with depression, only this one now involved the abnormal patterns of the stress hormone cortisol, and it also predicted early mortality, independent of other risk factors. So one of the questions we asked was, well, what is dysregulating this cortisol? And it turned out that these women told us that they were waking up more at night, the ones who had the abnormal cortisol patterns. So that got us interested in sleep disruption and how circadian hormone and sleep disruption could affect cancer. And I should just mention that Sandy Sefton, who was the first author on this paper, is now at the University of Louisville, and she found the same thing with lung cancer patients, that those who have the abnormal cortisol patterns die sooner. So it's been shown in gastrointestinal cancer patients as well. Disrupting the circadian cycle has an adverse effect on disease progression. And again, there are biological pathways, we think, that link maladaptive stress to abnormal patterns of hormones and immune function that may actually affect the rate of tumor growth. Here is the evidence we had from our patients. The ones who had the most abnormal cortisol patterns reported significantly more awakening during the night than those who had the normal cortisol patterns. So this may be one pathway that links stress and sleep disruption to cancer progression. Oksana Palesh, a new assistant professor in our department, whom we recruited from the University of Rochester, did a very interesting study in which she looked at the relationship between good sleep at night and what we call vagal tone during the day. Now, vagal tone is a measure of the activity of the parasympathetic nervous system. So we have two kinds of stress response nervous systems in our bodies. One is the sympathetic system. That's what I mentioned before, norepinephrine, epinephrine causes your heart rate to increase, your blood pressure to go up. There's a counteracting one, the parasympathetic nervous system, different neurotransmitter, acetylcholine, and it slows down heart rate, releases vascular wall strength. and it slows respiration. It tends to calm you down. It's a kind of self-soothing hormone. And it turns out that the women who slept better at night had more of this parasympathetic activity during the day. So they were better able to self-soothe. Now, this may seem a little unusual, but think about it for yourself. When you've had a really bad night's sleep, do you notice how much more irritable you are the next day? Even the most minor thing just sets you off, whereas at other times you would manage to remain calm. So we think that sleep helps people to self-soothe and manage stress better during the day via this increase in vagal tone, vagal activity. We're also observing now, and these are new unpublished data, that patients who have more sleep disruption at night, these are breast cancer patients, have shorter survival. So if they wake up more during the night, have trouble getting to sleep, have sleep apnea syndrome, in which they actually obstruct their airway when they fall deeply asleep, are sleepy during the day, or don't get as much sleep, are all likely to die significantly sooner years later. And this survival curve shows this. So the ones whose sleep patterns got worse and worse were the ones who died most quickly in the 8 years after we did the initial analysis of sleep. So it suggests that being in training, helping your body get the sleep it needs, may actually not just improve how irritable you are the next day, but how long you live 8 years down the road. We're now engaged in a series of studies of sleep and breast cancer. One is funded by the National Cancer Institute, and we're getting women into the clinical translational research unit. They spend 32 hours there. We are measuring sleep with EEG. We actually have a very long intravenous line that goes through a hole in the wall to the next room, so we can draw bloods throughout the night without waking the patient. So we're studying the changes in hormone patterns in relationship to sleep patterns. And we have not analyzed those data yet, but we'll start this summer, and we're very excited about that. Dr. Polish and I also have 2 sleep intervention programs ongoing now. One, the Mosaic study, and this is a study that Dr. Polish originated, knowing that cancer patients have many side effects of their treatment, including fatigue and sleep problems. I haven't yet mentioned it, but fatigue is a major problem for cancer patients, and it's obviously related to poor sleep at night. Among other things, and we thought that addressing them together might help breast cancer patients do better. We're testing a new medication, modafinil, which is a stimulant. The Air Force gives it to pilots to keep them alert while they're flying. We are giving it to some of these patients during the day to see if they feel less fatigued during the day and they sleep better at night as a result. We're finding it to be, so far, an effective treatment for sleep problems as well. Dr. Polish also developed a brief behavioral intervention to treat insomnia that occurs during chemotherapy. It addresses maladaptive coping behaviors, napping too much during the day, extended time in bed. And one trick, by the way, if you have trouble sleeping is if you can see your clock from your bed, turn it around. You don't want to be looking at your clock because that's an arousal cue. It wakes you up. We think that the combination of this behavioral therapy and modafinil may help, and so some patients will get both the behavioral therapy and the drug, some will get one or the other, and some will get a placebo, and we'll see at the end of the study who does better and which is the most effective part of treatment. We also are doing a study funded by the National Center for Complementary and Alternative Medicine looking at acupuncture and how acupuncture may help patients sleep. Many report it is actually a relaxing procedure to go through. So we're recruiting women with primary and metastatic breast cancer, and if any of you are interested in either of these studies, please let me know and I'll give you some emails, contact information. And they will get either sham or real acupuncture. So you'll either have, you'll get acupuncture treatment, but one has the needles that actually penetrate the acupuncture points. And we'll see to what extent the acupuncture treatments twice a week help you sleep better at night, and we'll be assessing that. So we're hoping that some of these new, relatively non-invasive techniques will help women sleep better, live better, and perhaps longer as well. So Dr. Polish can be reached at opolish@stanford.edu, 725-7011, and our project coordinator, Monica Jung. Go for the phone number. The email is complicated, but It's 725-4193. So some final comments and conclusions. We're beginning to think that helping people live better may actually help them live longer as well. We've been doing group therapy for many years for cancer patients. This is a psychoanalytic take on it. And one of the surprising things that we found in helping people form networks of support, express emotion, cope with their existential fears, change the way they relate to people, their family, and their physicians, and use techniques like self-hypnosis to help control their pain, is that they seem to improve the quality of life and may even extend the quantity of life. We found that women randomized to group therapy actually lived longer than control patients on the same kinds of standard medical treatment. And since we're running out of time, I'll go through this very quickly, but just say that there have been a number of other studies now that are supporting the same conclusion from other places. So Barbara Anderson at Ohio State has found the same thing, treating women with primary breast cancer with group therapy, and shows that the ones who get the treatment live longer than control patients who get routine care. And this was a study just published last summer in the New England Journal of Medicine for end-stage lung cancer patients, showing that those who were randomly assigned to get palliative care treatment not only were less depressed, that's the pink bars here, but they actually lived 2.5 months longer than those who received standard care, despite getting less intensive chemotherapy. So these techniques can be very helpful in helping people live better and potentially live longer as well. And in addition, we can very effectively treat problems like depression and pain. I've worked with Dr. Shortliff in a study with children learning self-hypnosis to get through invasive procedures in which their bladders have to be filled. And they get through with half the pain and anxiety, and the procedures are shorter, 17 minutes shorter. So there are a lot of things we can do psychologically that help people live substantially better. So this is our French cancer patient who said, well, you know, it's a bad thing, but you have some good days, and you'll notice her hair has grown back. And she did the typical French thing with the cancer. She barbecued the crab. She made a meal of it. She says, alors courage. And so there are ways of facing and dealing with this illness that will help you live better during the day, sleep better at night, and maybe live longer as well. The thing I recommend is the acronym FACES. Face rather than flee. Alter your worldview, learn to cope actively with the disease, express emotion, and seek social support. So you can go from feeling damaged and injured to feeling that you have transcended and that you can live well facing what you have, but live beyond it as well. He's saying I was close to a breakthrough when the grant money ran out. That's certainly a problem with the current federal budget, I can assure you, but we've been very fortunate to have support from the National Cancer Institute, the National Institute on Aging, the National Institute of Mental Health, and the California Breast Cancer Research Program, among others. Shakespeare said, when we our betters see bearing our woes, we scarcely think our miseries our foes. The mind much sufferance doth o'erskip when grief hath mates and bearing fellowship. But the mind-body relationship is nothing to fool around with. He's saying, what happened here, Sergeant? He said, it's a placebo overdose. We're pretty sure he only thinks he's dead. Thank you for your attention.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.